Good evening. Today we're going to be talking about public health legislation. It's a pretty broad topic. It impacts many, and specifically, we're going to be addressing that with healthcare. The topic today that we're going to target is one that's been relatively hot, actually, in the market for diversity and inclusion in the medical healthcare space. Diversity is what we could say is being invited to the party. Inclusion is being asked to dance. I'll say that again. Diversity is being invited to the party. Inclusion is being asked to dance at that party. So while many believe that this is a gross oversimplification of some of the issues that do exist, it does give us context regarding how we can begin to understand some of the issues that exist in healthcare. Many healthcare organizations have worked to implement more and more diversity. However, we still see a struggle with the inclusion. The population of medical healthcare providers still remains well below balanced. The majority of healthcare field is represented by Caucasian Americans or white Americans. African Americans, Native Americans, Hispanics, Asian, and Indian populations are extremely underrepresented or underserved in this community. That being the case, when we have several populations that are diverse and represent such, this can cause or contribute to a gap in care. According to the decision handed down by the U.S. Supreme Court in Students for Fair Admissions, President and Fellows of Harvard College, there's race conscientiousness in admissions policies for students. However, it doesn't hold up. It still fails to meet a scrutiny test. And these type of tests allegedly require that racial classifications are used and the consideration of different ethnicities is necessary to advance interest. Maybe not so great there, right? Diversity and inclusion, they were not always terms that were associated with each other. In fact, the combination of such terms is just recently being used as a pair and being intermixed with the discussion of healthcare in recent times. As a community, we have to understand how important it is to have a healthcare workforce that represents the tapestry of our communities as it relates to ethnicity, physical disability status, mental disability or stability status, gender, immigration status, socioeconomic levels, demographics, and the list goes on. Addressing these various populations is critical to providing some of the best possible patient care and ensuring that we don't forget how to create inclusion in those various population groups. We have various committees and liaisons who have already attempted to take a very active approach in this. Some examples would include Liaison Committee on Medical Education, LCME, the Institute of Medicine, IOM, and other medical organizations that are really working to improve diversity and inclusion in medicine. Essentially, they are targeting and trying to make big changes in the environment of medical care. Even so, we know that the efforts of such organizations alone are just simply not enough to make the bigger changes we still need to see come into play in order to reach our needed goals. So, in the following topic, we're going to discuss some of those actions and things that may still be needed to improve and who can help. As far as my own personal position, I believe that it will take something greater than human efforts to bring about a true balance to the medical and healthcare environment. Personally, I believe it will take the efforts of a higher power, that would be Jehovah God, the one who created man, to set all of the needed matters straight. In the meantime, however, we do exist in this system and we do deal with these particular imbalances, and I remain ready myself and prepared to advocate for my patients of all backgrounds and my peers of all backgrounds for the best healthcare balance that we can create with applied effort. As a representation of a minority within healthcare, I firsthand experienced the many challenges that exist both as a patient and as a caregiver as a result of having that lack of diversity and inclusion in our healthcare system. It is my utmost goal to see these type of disparities minimized and advancements made that execute a more sound and diverse and equitable environment. In most spaces, the gap or the majority of our clinicians are not composed of minority persons, and this can be received and sometimes is a disservice to some of our underserved and underprivileged communities. This can lead and contribute to poor outcomes, unfavorable interpersonal exchanges during visits and appointments, reduced amount of trust, impaired communication, repeat visits, and in some cases, even worsening of conditions up to and including death. The biases, structural racism, microaggressions, discriminations, all of these things must come to an end. So there's a call for action. Yes, you can help. This topic is not just brought out to bring to light some of these issues, but rather these have been issues for quite some time, and there has been lots of efforts to gain traction and direction. However, one of our largest calls to action on the topic is a need for leadership and mentorship, organizations that prioritize this topic as a priority and have authority within the leadership panel to make tangible changes within these areas. Of course, we want these groups to address diversity, equity, anti-racism, and inclusion. Some organizations have already commenced and have begun making some standing progress on these matters. CARE, C-A-R-E, has now entered its second phase, which will engage in a broad array of NAM staff and focus on advancing work in 3 priority areas. One of the approaches that they're taking is creating a roadmap for racial equity, creating a culture of racial equity, and then developing tools and having resources available to advance racial equity. Of course, this is not something that can be tackled very quickly or in an overnight fashion. And if there isn't some form of accountability or tracking, efforts such as these could end up going unresolved and not, in fact, making the greatest impact. One thing that we should be making sure of is that the purpose of the organization and what the goals are clear, outlined, and reached. There should be great endeavor to ensure that no person who seeks a career in health or science professions experiences a sense of exclusion or a lack of opportunity to advance or mistreatment, inequities in their responsibilities simply because of their ethnicity, demographic, culture, or race. When a minority feels that these type of behaviors arise, it would be most helpful to have some resources that they could communicate with and leverage those concerns immediately. This is another reason why having such organizations would be helpful. It'd also be helpful if there was a team of leadership that holds accountability to those in charge of making the major decisions in healthcare that contribute to these disparities. What is our industry leaders' perspective? Well, we have leaders and laws in place that should serve as a protection in many cases. Laws such as the Title VII of the Civil Rights Act and the Americans with Disability Act, prohibiting unequal treatment based on race, sex, and disability, they have, in fact, decreased overt racism in the healthcare setting. That's good news. It's been stated that some of them have even, in fact, improved the environment for healthcare workers, minimizing the issues, though there still remains a lot of work to be done. Additionally, there have been many different historical traumatic events that our country and cultures have experienced that have contributed to a heightened environment on this topic. We're remiss to remember that the killing of George Floyd in conjunction with the disproportionate burden of COVID-19 in communities of color has elevated the national consciousness regarding diversity and discrimination. Americans are becoming more aware that structural racism is causing healthcare disparities. Many communities still have not healed from the trauma of similar events and issues, which make it more difficult to progress at times. Establishing trust is a must in the community, and surely this takes time. Some of our scholarly research supports this. We do well to take note of how serious of a matter this is for persons of a minority background. They experience activities and situations such as this on a daily or regular basis, and it's just not fair. Research supports that much should be considered when determining how to approach the matter and what ways would execute the best response. There has been a substantial increase in attention to the issue of diversity and inclusion and a lack of it. Many organizations have actually expressed interest in addressing it with surface level efforts and even assigning a particular individual of a minority background over a committee, etc., to fix our diversity issue problems. In 2020, let's take a look at some of the numbers. Our U.S. healthcare workforce reportedly comprised of more than 50% white, approximately 20% Asian, 7% Black, and less than 1% Hispanic and Native American workers. 2/3 of physicians and surgeons are Christian, 14% are Jewish, and fewer than 15% represent other religions or atheism. In addition, 2/3 are men, although this is changing as more and more women are admitted to medical schools. Another, aspect of these ratios is that while it's worthwhile considering how many individuals or percentages are composed of such each ethnicity in the medical field, they're not generally separated according to the role. So the very 7% that represents the African American community are not necessarily all licensed nurses. That would be LPNs, licensed practical nurses, or RNs, licensed registered nurses. In fact, sometimes these percentages include non-licensed staff, such as patient caregivers, patient care nursing assistants, or state-tested nursing assistants. And that buffs the numbers even higher than what they really truly are, which is probably more around 2 to 3%, not 7. There's a strong argument that the fact is that the rations are actually more disparate than what some of these studies show. So in conclusion, it's very clear we have a national crisis lacking in the diversity population of clinical staff to support our diverse population of patients that we serve. It is no doubt that if we were to increase our diverse population of clinical staff, we will also increase some of our patient outcomes when serving those communities. We would do well to not only acknowledge the issue, but also have some form of legislative accountability put in place and have an increase in action-able membership organizations that wish to take a more active role in achieving measurable results of change. Well, due to a variety of factors, this will certainly take some time. One of the most important factors impacting the change is developing trust with the communities that we've impacted the most. And in the meantime, of course, we can always take a personal interest to increase our own individual efforts to improve these various matters that will not go unnoticed by patients and staff alike and are definitely valued to some extent. I certainly hope you've enjoyed this brief moment discussing one of the topics of our public health legislative healthcare, and we look forward to seeing how this will develop in our future. Thank you for your time.